me click that. Officially started. We will be sending everybody who registered the direct link, which will be to this video on our YouTube channel. So you can watch it again, share it, and also obviously anybody who was not able to watch it live will be able to see it. So welcome to tonight's webinar. This is Aortic Disease Awareness Week, and that's the whole week. And we wanted to bring you the latest in research in this area. Reason why we're doing this also is because we just returned from our international science meeting, Science in Paris. That's where we were in Paris, where 200 researchers from all over the world presented their work on Marfan, Loeys-Dietz, VEDS, and other aortic conditions. And just so gratifying to see all the work being done in this area. Not only the names that you know who've done so much research for decades, but also the young researchers who are bringing so much energy and passion to the field. And it's just exciting for us and exciting to know that all of you will continue to be served with the next generations of scientists. As Michael mentioned, we also had an international patient meeting where many representatives from different patient groups were there, and also patients and families were there as well. And that was really great to be collaborating internationally with these groups. Our entire year, we're going to be focusing on research webinars. So I'm going to be putting up later the dates that the upcoming webinars are. We know that we've covered a lot of the basics already, you know, the 101s, the different body systems, but we know everybody's excited about research and the hope it gives us all for the future. So make sure that you watch for those. We have more than 180 registrants so far. Not everybody's on now. We're getting up there. If you have any questions, please put them in the Q&A box, and we'll be going to that after Dr. Beagle does his presentation. If you could do us a favor, try to keep the questions short because I've got to read it all. And also try not to make it too personal because we want it to apply to everybody. So we don't need the whole background on your medical history, just kind of trying to ask the question generally. And if your questions are not answered tonight, I'll be putting up the way that you could submit questions to Jan Lynch, our amazing nurse that heads our Help and Resource Center. And she works with Joe Garima, who's our Chief Science Officer, who is there on your screen now. And as Michael mentioned before, she's there for color commentary and when Kim Beagle needs her. So I told you to be ready. Our next speaker tonight, before we get to the presentation, is our President and CEO, Michael Lemur.
Thanks, Eileen. Good evening, everyone. What a great way to kick off Aortic Disease Awareness Week. You know, we had a terrific summer. We had our annual conference, which is now E3. Joe was certainly key to that. Joe, as being our Chief Science Officer, was also key to the science sessions that happened in Paris. Lauren May, our Research Director, was her partner in doing much of that work. And now tonight we find ourselves in the fall. And we're, as Eileen pointed out, we're really circling back and looking ahead. We're circling back with some of the highlights from Paris, but we're looking ahead to the future of treatment and care for persons in our community. So it's great to have you with us. We have almost 50% of the people that signed up, which is terrific. A lot of people sign up and then naturally get the recording later on. Also, I'd like to take this opportunity to introduce tonight's lead speaker. It's Dr. Kim Beagle, who is an outstanding clinician and renowned researcher who brings together doctors and scientists worldwide to advance the field of genetic aortic conditions through ongoing dialogue, networking, international registries, and multi-center collaborations. A world leader in cardiology, he has served on committees for the American Heart Association, the American College of Cardiology, as well as the National Heart and Blood Institute. For more than 25 years, he has been at the helm of the International Registry for Acute Aortic Dissection, otherwise known as IRAD. It's a multi-center registry that has more than 11,500 patients. And he's also led over 100 scientific journal articles. In his spare time, Kim is also an avid freshwater fisherman or fisher person. Freshwater as in small fish, just to clarify what that is. And he will also gladly answer questions on that topic as well. So don't hesitate to put those in the chat box. With that, I turn you over to one of America's great fishermen, Dr. Kim Beagle.
Oh, Michael, you are so funny. Thank you for most of that kind introduction. Can you see me okay?
Yes.
See me fine? Okay.
Yeah.
That's great. So it's a pleasure for me to be with you. I really am embracing the relationship that the GenTAC Alliance has forged with the Marfan Foundation. We've been, I guess you would call, a division of the foundation now for a couple of years, but this consortium of investigators, which set out to study the genetic underpinnings of thoracic aortic disease now almost 20 years ago, was largely formed as a result of the efforts of the Marfan Foundation, which aggressively lobbied our Congress to invest more in trying to study rare but important genetic aortic diseases. And that led to the GenTAC Registry, which I chaired, and then the GenTAC Alliance, which the National Heart, Lung, and Blood Institute supported for several years. And our teams came under the umbrella of the Marfan Foundation a couple of years ago. And it's been a delight. The efforts of the foundation to invest in science and education and better care and prevention for genetic aortic diseases is unparalleled in the world, in my opinion. And for me to have a chance to interact with these kinds of people on a regular basis is a delight. And I'm sure I learn more than they learn from me, but I'm glad that we're working together. So as Michael mentioned, we had an international meeting just last month in Paris, and it was 5 days of meetings and science. And my task is over a few minutes here to try to give you some takeaways that I think were particularly relevant. And we're going to focus on cardiovascular disease tonight. I apologize, we're not going to get into musculoskeletal or eye or other very important aspects of some of the genetic conditions that are so important to all of us, but we'll focus tonight's discussion on the cardiovascular takeaways from that meeting. Now, there were well over 100 presentations. So as I culled through those and tried to think about what would I, as a patient or family member, want to know from that science, I tried to identify a few themes that I thought were important, and I guess I would say are representative of the advances that are being made. I think the first thing I would say to you is the good news is that we have around the world a group of both senior, mid-level, and junior scientists who are deeply committed to pushing back the frontiers that continue to provide barriers to successful diagnosis, prevention, and better treatment for all the conditions we're going to talk about. And when you get these people together in a single place and you see the range and depth and excitement about the work, it gives you hope. It certainly gives me great hope that we are going to continue to make progress in better understanding these disorders and treating them and diagnosing them earlier and earlier. So with that as a backdrop, I'll go through about a dozen slides that will illustrate some of the most important findings. After I'm done, I'll ask Jo Green if she'd like to make some additional comments, because she and I were both there and thinking about what science is especially interesting to the group that we're talking with tonight. And then we'll have plenty of time for Q&A at the end, and we'll hopefully be able to take some of your questions and try to get those out of the way as well. So let's go to the next slide. So this is the outline, and I'm going to start with some findings that I think are relevant to the full range of hereditary thoracic aortic disease. And then we'll talk about some of the specific areas related to Marfan syndrome that I think are important. I have a few major studies that I think are important to what I'll call the umbrella of Loeys-Dietz syndrome, a slide on vascular EDS, a couple of important papers or presentations related to bicuspid aortic valve disease, And then a couple of, I'm going to tantalize you with a couple of other slides that relate to interesting work just done, not presented in Paris, but just published, or an upcoming publication that I think is really going to be an important one for those who have genetic aortic diseases. So let's get started with the next slide. So there were a number of studies presented in Paris which looked at quality of life in children who have hereditary thoracic aortic disease. And as you might expect, in general, children who have genetic aortopathy have less physical activity than other children on average. And there was a study which actually measured that in a fairly large number of children who underwent a maximum stress test. How much exercise does a person do before they get into what we call the anaerobic threshold? And on average in this study, the children who had genetic aortic disease had about just 63% of the normal oxygen capacity with exercise that we see. And clearly, this relates to a number of things. Clearly, sometimes there is less muscle strength. And not infrequently, the medical profession is telling children who have thoracic aortic disease that's inherited not to do too much. And this is a source of great frustration, I think, for both patients and family members alike, and an area that really must be attacked with science. I was delighted to see at the meeting about 3 or 4 or 5 presentations looking at exercise. And these generally suggested that mild to moderate exercise appears to be safe. The French group, led by Guillaume Jandou in France, even have an online tool that they recommend to their patients and families that actually gives them sort of an exercise prescription. And I haven't actually seen the tool, but I'm thinking, Joe, we may want to make that link available to the audience so that they could possibly use it. Clearly, this relates to family history, body habitus, the severity of underlying aortic condition, et cetera. But we're all looking for more information that can guide activity. And in fact, I believe in 2 months, there's going to be a webinar specifically focused on this, led by Dr. Braverman and Siddharth Prakash. Also, the foundation is not standing idle. Foundation has just awarded a grant to have a study looking at this in a more coordinated way. And this is so important. There was one study at the meeting which actually suggested that moderate activity might delay aortic growth in children with Marfan-related aortic disorders. And if you think about this, when we exercise, our blood pressure goes up. And so if there's a fear that the blood pressure is going up too high, the natural tendency may be for physicians to say, you know, we really should hold this down. On the other hand, if regular exercise actually promotes aortic health, and if regular exercise actually lowers the resting blood pressure, you could make the counter argument, in fact, that regular exercise, if not extreme, might be quite beneficial to the child and aortic health. So this is an area of great need for more research. The early returns from fairly small pilot studies suggest that mild to moderate exercise is probably safe. And we just need more information as we forge the future in this very important area. Let's then go to the next slide. This was a study which actually was done by one of our imagers at the University of Michigan, Nick Burris. And one of the things that we've been trying to understand is if a person has an aortopathy, where does the aorta grow? What do we have to be watching? What areas at greatest risk? What areas might not be so vulnerable? And Nick did a very interesting study using a very sophisticated type of 4-dimensional flow using magnetic resonance imaging in about 70 patients with various types of inherited aortopathies. And what he discovered was actually quite unique. There were some patients who had their ascending aorta replaced, and the aorta just didn't grow at all after that. The downstream aorta just stayed the same, and everything was fine. There was another group where just beyond the Dacron graft and the ascending aorta, that's where the aorta tended to grow. And then there was a third group where it looked like beyond the graft, the entire aorta tended to enlarge. I illustrate this not to suggest that this is the final answer in terms of how aortas behave, but it illustrates the progress we're making with imaging. I'll talk in a few minutes about the progress we're making with genetics. And I believe the future is going to be far more personalized medical care, where the specific genetic problem, coupled with a family history, coupled with very sophisticated imaging, is really going to help us plan our therapeutics and also plan appropriate imaging surveillance to maximize benefit for our patients. So this frontier in imaging is right in front of us. 4D flow imaging right now is a research tool, but in a few years, it will be common. And it will, I think, vastly affect how we care for patients, and I think in a very positive manner. Okay, let's go to the next slide, Eileen. So where are we with biomarkers? So biomarkers are proteins that are circulating in the blood that we would like to be able to use to either diagnose or prognosticate certain problems. We use a biomarker called troponin to measure evidence that the heart muscle's been damaged with a heart attack. And wouldn't it be nice if we had biomarkers that allowed us to diagnose sudden aortic problems like aortic dissection with high reliability? For years, we've known that a biomarker called D-dimer, which is actually a product of clotting within the bloodstream, is virtually always elevated when a patient has an aortic dissection. So we would say that that biomarker is highly sensitive for identifying the problem. The issue with D-dimer is that it's not very specific. That is, there are other conditions that can also cause an elevation in the D-dimer. One example is a clot going to the lung. That's called a pulmonary embolus. Another is a heart attack itself, which sometimes is involved with clotting in the heart muscle and in the adjacent chamber of the heart. So investigators have been searching for an additional biomarker that might be coupled to D-dimer. If D-dimer is sensitive, and we had another one that was specific for the aorta, we would be in a nice spot. We could order those blood tests when patients with acute chest pain go to an emergency room and either raise the possibility of an aortic dissection or rule it out using just a blood test. For a number of years, an investigator at the University of Oregon, Lynn Sakai, has been working on this problem. And a few years ago, she reported that a biomarker called fibrillin-1 might be such a biomarker. In Paris, she actually showed that a different derivative of fibrillin, fibrillin-2, might even be better. It might have a more specific role in the diagnosis of aortic dissection. The problem with finding one of these biomarkers is that it requires an investment in developing a bedside assay that is highly sensitive to detecting very minute amounts of these proteins in the blood. And it has to be something that can be very quickly done. I can tell you, I worked on a biomarker called myosin heavy chain for over a decade with 2 companies. And even though in a research laboratory, we could identify that this particular protein was released, the company could never develop a reliable bedside assay that would actually work. So I'm happy to say that with D-dimer, at least, we have a sensitive biomarker that we can use, but it's not specific enough to be definitive yet. And we need more research to see if fibrillin 2 is that biomarker. Now, you may or know that fibrillin is one of the connective tissue elements, one of the elastic tissues of the aorta that allows the aorta to take the pounding that it takes. And when the aorta tears, there are proteins in the wall that get released into the blood, but small amounts. So the fibrillin group represents a target for a diagnostic platform using biomarkers. We will see. I'm hopeful, but we need reliable studies, and then we'll need a reliable assay that we can use at the bedside. Okay, let's move on. So this was a very interesting analysis. Shireen Shalhoub and others led a large group of patients to try to understand from patients and families what are the research priorities that you would have as a survivor of an aortic dissection. And this particular effort was funded by our national government through something called a PCORI grant, which is patient-centered outcomes research. And what I found fascinating about this particular analysis is that patients who survived an aortic dissection, the first thing they want is for educational resources to be made available to doctors so they'll more reliably and quickly diagnose this acute and life-threatening disorder. And this isn't a surprise, I guess, if you think about it, because it's currently estimated that almost half of patients who come with an aortic dissection will have the diagnosis missed at the first experience with an emergency department someplace. So this is the top research priority for survivors of dissection. Clearly, genetic testing is also very important to them. If I have had an aortic dissection, should my genes be tested for an inherited aortic problem? They also care a lot about educational resources. And we haven't, I believe, as a medical community, we haven't done nearly as good a job with giving patients and families the information they really need as we have focused on managing their acute problem. When we at the University of Michigan surveyed a group of aortic dissection survivors, we were stunned to find that a third of them reported depression. A third of them reported never having sexual relations again because they were afraid. A large group of them had fears that we could easily have dealt with if we just asked the questions the right way. And we really need to do a better job in what I call survivorship. How do we help you not just survive, but have a survivorship that's as healthy and happy and fulfilled as possible? Another, of course, is proper timing of surgery. And this continues to be a very important and moving target. And we'll talk a little bit at the end of my talk about where we're at with kind of when do we operate on an enlarged aorta, for example. Okay, let's go to the next slide. The Marfan syndrome presentations were numerous and almost too many to cite. I pulled just a couple. This top one is very important. That is, in a patient with Marfan syndrome, if we repair the ascending aorta, whether it's from an aneurysm or a dissection, the patient is still at risk for aortopathy downstream. And dissection beyond the repaired graft is not uncommon. Dr. Roman and the Cornell team showed that this was in the 1% to 2% per year group. A prior study reported about 2% per year. And if you think about this, if we repair your ascending aorta and put a fixed graft in there made out of Dacron, the kinetic energy coming out of the heart squeeze into that aorta, Dacron doesn't have any elastic properties at all. So that jet, those forces are going to go right into the aorta beyond the graft. And this property probably explains some of the worry that we have that the patient may develop distal disease, either aneurysm or dissection. So having an ascending repair is critical in a patient with an enlarged aorta or a dissection, but really careful follow-up of that distal aorta beyond the graft, including the arch and down the aorta, is also really important. And these patients have to be told that, you know, we've repaired your ascending aorta, but there could be a problem in the descending aorta. So any sudden onset of discomfort in the chest, the back, in the abdomen, you have to think, this could be something with my remaining native aorta, got to get to the hospital right away. There were several studies looking at the fact that there can be arterial abnormalities outside of the aorta, the branches of the aorta. And Shireen Shalhoub from the University of Washington reported that about 10% of their Marfan patients have shown a tendency for an arterial dilation or dissection on one of the branches. And this is most common in the subclavian artery or the iliac artery. I just had a patient in my practice who had really total repair and then developed a subclavian aneurysm. So we have to be very vigilant with watching not only the aorta in Marfan syndrome, but also the big branches, especially the arms and the legs. Another really interesting study was looking at the ability to subtype the exact genetic anomaly underpinning Marfan syndrome. Marfan syndrome is known to occur as a result of abnormalities in the FBN1 gene. But studies are beginning to mount suggesting that the exact type of anomaly may be informative in terms of expected risks. So if we think about what type of genetic anomalies can occur, there can be an amino acid switch in the genetic code, or there could be a deletion of a segment, or it could be a duplication of a segment. And so increasingly it becomes clear to us as we understand the exact genetic nature of a problem, it may inform the likelihood of clinical outcomes more than we thought. You probably know that there are way over 1,000 different types of FBN1 mutations that have been described. The future is probably to do more elegant genetic research, subtyping the specific genetic defect, and hopefully that will inform a more precise approach to patient care of both patients and families in the future. We're at the beginning. You know, we all hope that if we crack the genetic code, we could predict everything. Well, it turns out it wasn't nearly so simple. And this is the beginning, I think, of a new wave of what we'll call a deeper dive into the exact genetic issue that hopefully will inform practice even more. Let's go to the next slide. So Loeys-Dietz syndrome, there were a number of important articles or publications or presentations at the meeting. Two that I thought were especially important. Aneurysms of the arteries in the brain is something that we really have to pay attention to with Loeys-Dietz. Dr. Braverman at WashU showed that this occurred in 18 of 80 patients that they had. And the wonderful registry in Spain called the REPAC registry, the number was 21 out of 163. We want to screen our patients with Loeys-Dietz syndrome. We want them to have CT angiograms of the head to make sure that they don't have an aneurysm. This is a really important part of the initial evaluation and subsequent follow-up. Also, the REPAC registry in Spain suggested that some of the bigger branch arteries are also prone to aneurysm. They found that about a third, maybe a little over a third, of their patients did have branch aneurysms off of the aorta. So when we have imaging of Loeys-Dietz, we want to think about the brain, the entire aorta, and the big branches coming off the aorta to make sure that we're getting a total picture of that individual's risk. Okay, next slide. So the Loeys-Dietz syndrome now represents what I'm going to call an umbrella of patients who have similar clinical features, but they may be caused by a group of genes, not just one. When doctors Loeys and Dietz discovered the Loeys-Dietz syndrome, they were talking about genetics TGFBR1 and 2. And now we see a number of other types of genetic defects that produce a similar picture in terms of clinical situation. And I've listed, I think there are 7 now. And as we study Loeys-Dietz and these various types of genetic underpinnings, we are going to see that they may have differences. Just like I just mentioned in Marfan syndrome, a specific genetic defect may lead to a slightly different clinical scenario than another. We are clearly going to see that in this Loeys-Dietz umbrella. For example, Dr. Bowen at Mayo reported that the SMAD3 type had a higher frequency of a family history of sudden death, whereas the group in Houston said that the SMAD3 group also has more iliac artery dissections. And the group, the Montalcino Collaborative, reported that there were earlier events of the aorta in the SMAD3, in the TGFBR1 and 2 than in SMAD3 and the TGF-beta mutations. So once again, we're moving toward, I'll say, more precision. What specific genetic defects cause Loeys-Dietz syndromes, and how do those specific defects inform what happens, and what we should do as physicians in managing those patients? It's pretty clear that up until now, at least, the type of genetic mutation, the specific mutation, and the family history are really important. And so when we're working with families, more and more, we're going to try very hard to not just understand, oh, did the family have a positive genetic test for Loeys-Dietz? We're going to want to know, okay, what was that? And if we can find out from the family members or whatever was evaluated, if they had a problem, at what size did that occur? Was it an aneurysm or a tear, a dissection? At what age did it occur? These will be important as we get more precise with our diagnosis and our evaluation and treatment. Next slide. So vascular Ehlers-Danlos represents a really important effort of the foundation and of scientists around the world. And I would like to suggest that in some ways with vascular EDS, we're just beginning to explore the frontier. You probably remember that 30 to 40 years ago, one of the great breakthroughs in Marfan syndrome was the development of a mouse model that scientifically could be studied to get at the underlying mechanisms of why the disease actually happens. And this led to all kinds of things, including therapeutics that we use today. I was most excited, and this slide came from Joe Grima, who beautifully put it together, was really at, okay, what do we know now that we didn't know before about the underpinnings of vascular Ehlers-Danlos? And a couple things came out of the Paris conference. One is that there are natural modifiers of the variability, and we need to find out exactly what those modifiers are. How the cells on the lining of the blood vessels talk to each other clearly appears to be important in whether the blood vessel will dilate and or dissect and or rupture. There's already early evidence that inhibition of certain things like androgen or mineralocorticoids, which are basically vascular hormones, might inhibit growth. And even that statins that we commonly use for coronary artery disease might have a benefit on arteries of patients with vascular EDS. As you probably know, there are 2 large randomized trials ongoing right now, testing 2 different theories. One is a beta blocker to try to improve arterial health, and another is a more basic mechanism looking at growth factors that tries to improve health, that came from the cancer research. So now that we have mouse models of vascular EDS, I think we have hopefully tools that will lead to a deeper understanding of the disorder. And this hopefully will give us signals to attack both diagnostically and, most important, therapeutically. Next slide. So bicuspid aortic valve is a very common inherited disorder of the aortic valve. And a certain percentage of patients, 10 to 35%, also have an abnormal aorta. I think it's estimated in our country about 1 in 1,000 patients born has a bicuspid aortic valve. Normally, your aortic valve, if you looked at it on the end, it looks like a Mercedes-Benz sign. It has 3 leaflets that open. But sometimes there's just 2. And if there are just 2 leaflets, that valve tends to get narrowed over time or leak, and the aorta above it can develop an aneurysm. So there were a couple of studies at the Paris meeting focused on the aortopathy associated with bicuspid aortic valve. One of them suggested that how tortuous the aorta was much more likely if the enlargement of the aorta was up above the valve a little way, not just right on the root of the aorta. This could be important because we know a tortuous aorta is an aorta that's more likely to either dissect or form an aneurysm later. So the type of enlargement of the aorta may inform other parts of the practice of caring for these people. Also, a big concern in patients with bicuspid aortic valve is, what about pregnancy? We know from the literature that there has been concern that if a patient has an inherited aortic condition like Marfan syndrome, if the aorta is enlarged, we're worried that the physiologic state that pregnancy induces could cause that aorta to grow or tear or rupture. And so is that true for bicuspid aortic valve disease? Well, this was a nice study which looked at about 47 women who had 103 pregnancies, and 40% of them had an aorta more than 40 millimeters in diameter, which we would consider fairly enlarged if it was a Marfan patient, for example. And there was not a single dissection among those 103 pregnancies. This certainly gives us, I think, I'll say, information that suggests that probably the aortopathy associated with bicuspid valve isn't as likely, perhaps, as other inherited aortopathies to have a problem surrounding pregnancy. That's certainly the sense that we have based on the current knowledge. The other question that comes up sometimes in bicuspid aortic valve disease when there's an aortic enlargement is, do we need to do genetic testing? Could this patient have 2 problems, a bicuspid valve and a separate inherited aortic problem? And there was a nice study presented in Paris that looked at that. And it did show that genetic testing in bicuspid valve-related aortopathy was positive in about 16% of patients. But interestingly, all of those patients either fit into what we would call a phenotype typical for a look, if you will, of Loeys-Dietz or Marfan syndrome, or they had a family history of sudden death in a first-degree relative. And so this gives us some guidance in terms of, okay, if I have a bicuspid valve patient in my practice and they have an enlarged aorta, do I need to genetically screen them? And the answer probably is, yeah, if they have a first-degree relative who died suddenly, you should. Or if they have other factors that you look at and say, yeah, this could be a patient who has a separate Marfan condition. Yeah, I should do that in that particular circumstance. Next slide. So a couple of other updates that I think are interesting and timely. The IRAD group that I have the pleasure of chairing over the last 25 years published about 2 weeks ago a paper in JAMA Cardiology. And what we wanted to know was, what is the early mortality of a patient with a type A dissection? That's a dissection of the aorta in the proximal part of the aorta, where we know going to surgery right away is really important for survival. If you look back to when aortic dissections were really studied hard, mid-1950s, early 60s, it was estimated that 37 to 50% of patients with a dissection were dead within 7 days, and a good share of them passed in the first 24 hours. The IRAD registry showed that the early mortality for dissection, if you get to the hospital and you're stable, is maybe 0.1 0.2% per hour. This is really important because studies also show that if you end up with an aortic dissection and you're in a hospital that rarely operates on the aorta, like less than 10 a year, your mortality is a lot different than if you go to a place that operates on more than 50 aortas a year. The number can be 3 to 4-fold difference. At the hospital where I work, our mortality for type A dissection repair is about 5%. At a small hospital 20 minutes away, it might be 25%. So what this suggests that stable type A aortic dissection, if a high volume center is available close by, we should probably transfer that patient and move them to the higher volume center where the surgical mortality is so substantially lower that it's worth the small risk incurred by the few hours to transfer, which usually is in the range of 4 to 6 hours. So this is an important study that received, I think, a lot of attention, and it really does suggest that aortic centers of excellence, regionally spaced, are the way to go in America for managing type A aortic dissection. The other thing I want to prepare you for is that there are going to be new guidelines on managing aortic disease published by the American College of Cardiology and the American Heart Association. Those guidelines are expected to be released probably next month, if not the following month. And they're going to have quite a few advances that I think will be important for care. And the next slide is just a sneak preview where what we are going to be seeing with the newer guidelines is, if I ask the question, at what size of my aorta should I consider repair? It's going to be much more precise. This particular figure shows the aorta size in the blue arrows, and then underneath, different groups where we might be repairing the aorta at a different size depending on the gene, depending on the family history, depending on growth of the aorta. And so I'm really excited that the scientific progress that's been made in the last 10 years since the last guideline, much of it supported by the Marfan Foundation, is taking hold in the guidelines that inform national practice of the management of aortic conditions in this country. And this particular guideline is going to have a lot of information that caregivers are going to want to embrace. And we'll be covering the guideline more on the foundation and in GenTAC as we dissect all the recommendations and think about what that means for you, the patient, and or family member. Next slide. Some final comments. Having a face-to-face scientific meeting is just so different than a Zoom meeting. The chance to really chat with scientists and caregivers, patients and families, that's the magic of medicine. The human touch, the relationships that we build. That is the secret sauce that drew me to medicine and continues to completely mystify me. And we had that in Paris, and it was absolutely wonderful. And the foundation's team, Lauren May, Joe Grima, Eileen Michelli, Elaine Baruch, Michael, and others, created an absolutely splendid meeting that was absolutely stunning in terms of its output. I think the meeting also talks about the notion that we build the house of aortic management one brick at a time. We can't get too excited about a single brick, but when we start to build a wall, then we start to see something. And we're really seeing that now more and more with how we manage patients with Marfan syndrome and Loeys-Dietz. I'd say we're just starting the foundation for vascular EDS, but it's exciting. And we need to do better, and there's urgency to do better and to do more. And the foundation continues to lead the way in trying to invest in the education of patients and families, the caregivers that are out there on the front lines managing patients like you, and the science to try to develop a better way, earlier way to find and treat aortic disease more effectively. So I hope this has been insightful. I tried to do my best to give you a few tidbits from a magnificent meeting in Paris. Let me see if Joe would like to comment as the chief scientific officer, person who really organized this meeting. Joe, do you have comments you'd like to make?
Sure, thanks so much. I'm hearing a echo. It's good.
You're good
Okay.
now.
I'd just like to bring up one other study that was released during the Science in Paris meeting. And the foundation has a statement on it on our news section in our website. And this is about a study that analyzed all the clinical trials that were done globally, trials that were done in the United Kingdom, in Canada, in Spain, in the US, in the Netherlands, and in Belgium. So there were 7 trials with data from 1,442 participants. And the study was basically done to analyze the whether angiotensin receptor blockers or Losartan can reduce aortic enlargement in Marfan syndrome patients. So the study indicated that ARBs or Losartan significantly reduced the rate of aortic enlargement about half with or without beta blockers. And this effect was generalizable to all different types of patients. But in particular, ARBs were effective among those already taking a beta blocker and patients that actually had a pathogenic FBN1 mutation provided additional support for the use of that drug. So we have a statement on our website. There is a paper that was published in the Lancet. And this is all leading up from, several years of clinical trials looking at Losartan. And it looks like from this meta-analysis that the ability for Losartan to really help reduce aortic growth is real from the data that showed from the study. So that's the only other study I think I want to highlight tonight.
Thank you, Joe. Totally agree with you. That report was really important because some of the individual reports were not clarifying, and putting all those trials together was really a very smart thing to do, and I think gives us clarity on that question.
Mm-hmm.
Thank you for adding that, Joe. I'm going to go to the Q&A box. Kim, that was really great, but people do have questions. Jane is asking if there was any research regarding Fibrilin 2 variant of uncertain significance in the US.
Yeah, that is a very good question. I'm going to play ignorant here and say I believe so, but I'm not sure. Joe, do you have anything with that?
I don't. I don't think there is a lot of information about the FBN2 gene on aortic enlargement.
And it's a very good question. I actually have one of my patients who has an aortic condition and has that VUS, and we're simply waiting for additional information as some of these items get more studied to be sure whether it is important or not. Good question. Unfortunately, I don't have an answer. We might possibly, Eileen, throw it at Siddharth. He may have in his research an answer for that, so we should try to see if we can get any more information on that.
Excellent. Okay, I'll remember to ask him. What are the latest recommendations for frequency of imaging for Loeys-Dietz?
Yeah, this is a really good question. So this obviously will depend a lot on is the patient new to the system or not, and we tend to adjust imaging based on size of the aorta. So certainly the tendency is to image at least annually, and in higher risk individuals more frequently than that. I always will image at sort of time zero and then at 6 months, because I don't know if there's a growth rate that might be, that might be quick. And then after that, it's individualized. So it's a good question, and one that I think we need more information on.
Okay, thank you. Regarding HTED in bicuspid aortic valve, do all affected family members also have BAV, or do some have TAD with normal aortic valve? For example, is there still risk for TAD in a FDR with normal valve?
That is such a great question.
We have smart people here. They're going to ask you hard questions. There's no easy webinar here, Kim.
Yeah, so that's, yeah, you have me on my heels. There are families where the kind of the index patient has bicuspid valve and aortopathy, and a first degree relative may have a tricuspid valve and an aortopathy, and another family may have a bicuspid valve and no aortopathy. So we've seen everything under the sun, and trying to give you a percentage for how often that happens is very difficult. If you ask the question, well, if I take care of Mr. Smith and he has a bicuspid valve and enlarged aorta, what percent of his first degree relatives are going to have an aortopathy or bicuspid valve? That varies from 10% to 35%. It's all over the map, depending on where the patient is studied. So the answer is yes, it can happen. So when I find a bicuspid aortic valve person in my practice, I say, I want to screen your first degree relatives for both bicuspid valve disease and aortopathy.
Great. Karen, who we know, she wants to know, is Valsartan as effective as Losartan in diminishing growth of the aorta?
Yeah, Karen, you're right on there. That I think that the class of ARBs, there is some variability, and I actually prefer Valsartan or Irbesartan over Losartan because I believe they have a longer bioavailability than Losartan. So I'll tend to start my patients on one of those. One of the larger trials, I think it was called AIMS. You might remember this, Joe. I think it used Irbesartan at doses of 150 to 300 milligrams a day. So I tend to use the newer types of ARBs, but if I go back to more of a purist, I think Hal Dietz might be a purist. He would say, wait a minute, we studied Losartan at these doses. If you do this, it's going to be right. I can't quibble with that. I mean, he's the father of the whole dang field. But I tend to use Irbesartan and Valsartan for the reasons mentioned. But we have to make sure we push the doses to the levels that we think are commensurate with the Losartan trials in order to be getting the right effect. It's not just blood pressure. It's pushing the doses to trial level.
Yeah, and I think that is in fact right. I think Irbesartan is probably the ARB of choice because, as you said, it is slightly more potent and available. The United Kingdom trial used that and showed very good results with that drug. So I would say yes to that question.
Thank you, Jim.
Thank you both. We didn't talk about this tonight, but I know there were some presentations in Paris on surgery. So Robin wants to know, is there research into alternative materials, maybe more flexible or expandable for aortic repair?
Yeah, what a wonderful question that is. And I'm certain that virtually all of the companies that make grafts are trying to find a more elastic yet durable substance than Dacron that would stand the test of a lifetime of pounding from your heartbeat. So I'm aware of small studies looking at that using animal models. I'm not aware of any large human trials that have come to my attention, at least, that look promising. Joe, do you have any other information on that?
I do. There is another type of surgery that's being tested in mainly in some countries in Europe, using a Dacron graft, but it is modified to have a larger pore size. And so the cells of the aorta grow into it, reinforcing the aorta. This is called the pairs surgery. That device is currently undergoing trials to get FDA approval, and that would probably happen in the next few years. But it will take additional training of surgeons because the surgery is different using that graft.
Am I right that the graft is wrapped around the aorta?
Correct. Mm-hmm.
And so the if you want to see an interesting debate, get one of the old guard cardiac surgeons debating a new guard cardiac surgeon on the potential of the pair operation. And we saw some sparks on that topic in Paris, and I think we will until there's a definitive and long-term trial. The thing about that is, even if you wrap a fixed graft around the aorta, it will get to a certain point where it does not extend, and then do you transfer that kinetic energy downstream like you would have anyway? We don't know. And that one of the challenges with these studies is, if you don't study the patient for 5 years, you haven't studied them long enough to know. And so this is a really, really challenging problem for us to solve with research.
Yeah, and I think right now, there haven't been a lot of patients that have undergone this surgery in Europe. And that's one of the drawbacks, is that it's very hard to get definitive data from a small group of patients. And so, as the safety profile gets developed, and the long-term durability of that surgery keeps going, that's what's needed to, for that to be able to come to the US and determine, how well tolerated and how well durable that is.
Yeah, great points.
We're just going to go back to one more Losartan question before we end this Q&A part here. Glenda is asking, you mentioned, Joe, about pushing the doses on Losartan. And so Glenda's asking, what dose of Losartan do you recommend? Obviously, it's individual it's individualized, but what did the study look at? And can you talk about that a little bit?
Kim, do you want to take that? I mean, I think there are differences, what the standard is and what the amount that you push.
Yeah, so that I think the point is that for at least a patient with Marfan syndrome, we're not just treating the blood pressure. We're going to try to use doses of Losartan that have been used in the trials. So, in my practice for hypertension, for example, I might start a patient on 25 milligrams a day of Losartan. That's a very small dose. And in treating Marfan patients, we're trying to get the patient on 100 milligrams twice a day, or even more, to try to maximize the effect of that drug on angiotensin receptor blockade, and with that, the aortic biology. So we're pushing to those higher doses, 200 milligrams or more. Great.
Thank you for that. So with that, I just want to end this Q&A section. And I did leave Jan's, the website where you can access Jan up on the screen while this was going on. So if you have more questions, or somehow we skipped your question or something, I wasn't on purpose. So you can go to marfan.org/ask, and that's Jan Lynch, and she will be more than glad to help you out. And if she doesn't have the answer, she'll obviously go to Joe, she'll go to Kim Beagle and our other professional advisory board members to get answers for you. So thank you both for taking all those questions. We did go through mostly all of them. So that was really great. I know we've been talking about more webinars here, and our next webinar is next week, and this is coming from the GenTAC Alliance. Actually, the GenTAC Alliance has different working groups, and this one is coming out of the group that focuses on patients, families, and clinicians' education. And this is something new that we're doing, looking at European and US perspectives on different topics. A lot of the questions from patients and families are the same, and a lot of the guidelines are the same, but there are some interesting areas for discussion. And so this webinar is going to be in the middle of the day next week, so it is really convenient for our community over in Europe. And I know we have a lot of them here on this call tonight. So we have Dr. Mary Shepard from Kentucky, Dr. Melissa Russo from Brown here in the US, Dr. Julie de Backer from University of Ghent, and Dr. Martin Cowling from Erasmus in the Netherlands. All excited to bring you more information. That link will also be in the follow-up email that I send you guys later this week. So hopefully you can make that. And then our whole research webinar series, as I said, this one tonight is our first. Dr. Eagle did allude to the next one, which is physical activity, November 9th, with Dr. Alan Braverman from WashU and Dr. Siddharth Prakash from Texas. And then in February, we'll have a webinar on the latest research in genetics, which will be given by Dr. Loeys-Dietz. That'll be Marfan Awareness Month. Dr. Enid Neptune will talk to us about the latest research on lungs in March. And we have Dr. Jefferson Doyle from Johns Hopkins talking about some eye research that he is doing, funding from the Marfan Foundation. We're proud about that. Also, our VEDS movement is going to have webinars on the A2 clinical trial, which Kim mentioned earlier tonight. That's on October 27th, which will be in the evening for those people in the US, and then November 21st will be during the day for people in Europe. So trying to reach everybody and help you guys get access to the experts and get the latest information. So watch your emails for those. And, Kim mentioned earlier how great it is to be back in person so we can all network, and whether it's scientists or patients and families, that's all important. So we have 2 in-person symposiums coming back. So if you happen to be anywhere in or near Seattle or would like to go there, please join us on October 8th. And Seattle Children's Hospital is our host. We have an amazing facility there, a great lineup of speakers. Dr. Shalou will be speaking, as will Dr. Peter Byers. Dr. Lu Chiang will also be speaking. She's our host and key person on this. They're all on our professional advisory board. Dr. Glenn Iannucci is leading the charge in Atlanta, where we'll be the following week. So one's October 8th, one's October 15th in Atlanta. And we'll have doctors from other hospitals in Atlanta as well. So 2 great lineups. If you are in the area, please join. Not only get to hear great talks, but meet other people in the area who have these conditions. So we're excited to be back in person. Also in person, our Walks for Victory. And that's another great way, not only to meet the doctors and hospitals in your area who are supporting us, but also obviously to meet other people in the community. We had our first one yesterday of the year. It's in Cleveland at over 350 people there. Next, and then another week or so we'll be in St. Louis. We're coming to Ann Arbor, Michigan. We can also visit Dr. Eagle when we do that in the spring. I should also mention that we're having a symposium in Ann Arbor in the spring too. Anyway, there's the whole list of Walks for Victory. Go to marfan.org/walk. And if you don't have one in your area, please participate in our global walk. We're going to have teams from all over the world. And of course, if you don't have a team in your local area, please join us. You can do something in person, locally that day, or participate in our global virtual party with our incredible DJ. So that is going to be an exciting year for us. These walks fund so much of our programs and services. So they're really fun and obviously have been a big impact on what we can provide for all of you. And a couple of other special events that I wanted to point out just coming up really quickly. HeartWorks Houston is next weekend. We'll be honoring Dr. Shane Morris. Evening with Heart Scottsdale is November 3rd. I really want to highlight the VEDS Birthday Bash. It's the 3rd annual, and obviously it's a birthday party, but it's virtual, so everybody can participate. And whether you have VEDS or another condition, I think it's really great that we can all get together and celebrate all that's been accomplished by the VEDS movement and our director of that, Katie Wright, and who works closely with Joe. The research excitement there is palpable, and we're so excited to support this community and come celebrate with us on October 6th. And again, I'll put all the links in the email that I sent out to you all. So that is all I've got for you all tonight. So thank you all for joining. Kim, do you want to have some final words for this group of people who've hung in there with us about an hour, a few minutes more?
Yeah, first of all, I want to thank the team, especially Eileen, for producing this, for Joe for everything she does for the science of the foundation, and all of you. As a physician, it's a privilege to be involved with the foundation and with education of patients and families. I think you'll find that all of the experts that are part of the kind of the Marfan Foundation community are so excited to be directly linked to patients and families. Your questions are the ones that are important, and we're trying to analyze those questions and break them down into scientific questions that we can answer. And really appreciate your hanging in there tonight with us as we talked about some of the interesting findings from Paris. Thank you very much.
And Joe, I want to give you the last word, driving all our science here. So
I just thank you for participating. I hope that we answered your questions. And, we're always here to help with other issues. Jan, our nurse, is as well. And thank you very much.
all right, thank you, everybody. Have a great night. We hope to see you next week on our next webinar. Take care.